Chapter 10, Tumor Markers. We utilize certain elements within the body as markers for indicators of cancer. Due to specificity and sensitivity issues, we don't normally use them for screening or diagnosis, but mostly use them in monitoring treatment to detect if there has been a reoccurrence and prognosis of the patient's disease. The criteria for a good marker is listed in your text on page 226. We want something that's easy and inexpensive to measure. We want it to be specific for the one we're looking for. We want there to be a direct relationship between the amount and the size of the tumor. And we want it to be abnormal when other indicators are not abnormal, not revealing that they have this tumor. And we want these elements to be stable along with sensitive. Please refer to specificity and sensitivity. Most of the methodologies we use now are immunoassays, but there are mass spectrometry and microarrays that are available, just not generally in a clinical setting. These are some examples of tumor markers. They can be an enzyme, and as we learned with enzymes, different organ systems use or produce different enzymes. So these are not real specific. As you can see, I listed a few examples to show you they're from multiple organs. Hormones are utilized. They also come from multiple organs, but they're a little bit more specific. And if we had germ cells, that usually is pretty specific. On table 10.2, there's a whole long list of different markers and their associated cancers. But box 1 lists the most commonly markers that we do test in a clinical setting. So there's just a few that we are mostly concerned with. We're going to talk about a few of these. PSA is prostatic specific antigen. So this is a case of where we're doing an immunoassay. The antigen antibody complex for the patient's element is the antigen. It is a glycoprotein. We do have a free and a complex portion. If we can measure the free rather than the complex, that's even more specific. It is used for screening for prostatic cancer. There is a condition of benign prostate hyperplasia. This will help us to differentiate between cancer and this benign state. They're normally done annually on men beginning a certain age. And they're looking for a change, not specifically the figure of the final result, but a change of more than 2 nanograms per mil from year to year. There's also a different order category called diagnostic. Once a patient has been diagnosed with prostatic cancer, they may follow up more frequently than annually, so it has to be billed a different test code, and so you may see a diagnostic cancer, a diagnostic PSA test order, which is different than just your annual screening. We have several breast cancer markers, and as a note, please note we have a lot of CA elements. Stands for carbohydrate. Okay, CA 15.3 is the most used marker for breast cancer, but the others can be used for different reasons. For instance, CA 549 and 27.29 are utilized for reoccurrence in our patients. You have also the HER2/neu is used as a prognostic indicator. And with more specialized testing, we can do the BRCA1 and 2 to find if you're a genetic carrier. And you've probably read some stories where women did test for this when they had a lot of occurrence in their family, choosing to go ahead and do mastectomies before the cancer had an opportunity to take hold. CA125 is elevated in ovarian and uterine cancers. It's most useful for the epithelial ovarian cancer, and we mostly use it as a marker for reoccurrence. Another more generic marker we use is CEA, Carcinoembryonic Antigen. This is not specific for colon, but we do utilize it along with fecal occult blood test for screening, and we're mostly looking for that blood in the stools. But if you had both of these, then they would do further testing. But colon cancer has a 50% mortality rate, so it is a very, very serious killer in the States, and can easily be prevented or reduced at least by polyp removal. Pancreatic cancer utilizes marker CA19-9. It's also more of a prognosis. We're not going to get into a lot of the bladder cancers, but it does seem to be occurring more often than it used to, so I can see that this will probably increase in the near future. Let's talk a little bit more about CEA. It is in the embryonic tissue, but after birth, it can reoccur with benign diseases. We mostly use this for monitoring CEA, and you will be testing CEA frequently. But this shows you how it's elevated in a lot of different cancers. However, the highest one is colon, and that's where we mostly use it. These are the markers I want you to know what we utilize them for